Every time he asks.
Welcome back. We are at that point in our day. It's the last witness panel. To start things off, we have a couple of slides, so let me turn it over to David.
All right, good afternoon. Welcome to the final session of this 7th annual Cost Trends hearings. We have a great final panel that I know will bring together a lot of the different themes that we've heard about over the last 2 days. I will be very brief in my introductory slides because we have such an esteemed panel and we want to hear from you. So I'm going to not show all of the slides that I had prepared as introduction here, but do want to focus on 3 key stats before diving in. So the first slide here is just a reflection of the increasing concentration of hospital care in the top 5 health systems in Massachusetts. So from 2010 to 2017, the share of hospital care in the top 5 systems increased by 18 percentage points, while the share at independent community hospitals declined by 16 percentage points. And this is a dynamic driven by hospital acquisitions and consolidations during this time period. The second data point is around the share of patients who are going to community hospitals or to academic medical centers for scheduled non-maternity low acuity care. And what we found was that from 2010 to 2017, approximately half of patients whose closest hospital was a community hospital traveled to a non-community hospital for scheduled non-maternity community appropriate care. And that trend has not changed over time despite efforts to move care to lower cost settings. And the final slide I'll show here is one that we started these cost trends hearings reflecting on, which is the trends in hospital spending versus hospital utilization. And what we have found is that there have been a significant increase over time in commercial spending on hospital care, even as utilization has continued to drop. So with those 3 data points helping to anchor some of this conversation, I'm happy to turn it back over to our Vice Chair, Marty Cohen, and to Commissioner Cutler, who's going to help lead this particular panel.
Thank you. I will help lead it. Why don't we just go through and let everyone introduce themselves and their organization briefly, and then I'll start off the questioning, and my guess is it's going to be a free-for-all, just the way these things go. Tom, should we start with you?
Sure. Good afternoon. My name's Tom Croswell, and I'm the CEO of Tufts Health Plan. We are a nonprofit organization, nationally recognized for our commitment to providing innovative, high-quality healthcare coverage for everyone, regardless of age, income, or circumstance. We insure about 1.2 million members and employ about 2,900 people, most of whom are in Watertown, about 6 miles from here. Our mission is to improve the health and wellness of the diverse communities we serve. And guided by that mission, we offer a broad array of high-quality health insurance products across every segment of the Massachusetts market. We're honored to be the largest health plan in the Commonwealth committed to government programs, including participating in the Mass Health ACO program with 4 ACO provider partners, 3 of whom are actually represented here on the panel. We've been recognized by CMS again this year with its highest 5-star quality rating for our Medicare Advantage plans, and by NCQA with a 5 rating for our commercial health plan products that we offer to employer groups, including the Group Insurance Commission. So we are very much committed to providing high-quality products. Thank you very much for inviting me here to testify. I would just offer a couple of brief thoughts about our collective efforts to meet the cost benchmark and what we might consider in the future. As you know, Chapter 224 created accountability for payers and providers.
Tom, can I just interrupt you for 1 second? Can you just pull the microphone a little closer?
Sure, sorry.
In order to foster coordination amongst you, we have provided not enough microphones, which means that if you can share microphones, the world will be a better place.
Terrific, thank you. As I said, maybe not everybody could hear, Chapter 224 created accountability for both payers and providers. We view that very much as a good thing for our customers and the residents of the Commonwealth, and would like to see the same focus on accountability extended to pharmaceuticals. As the recent CHEER report shows, pharmacy trend continues to be one of the largest areas of driving healthcare expenses. It grew 5.8% in aggregate and 3.6% net of rebates, both above the benchmark, resulting in increased premiums for our customers and increased costs for government programs. We also support many of the provisions in the governor's bill and look forward to working with the administration, the House, and the Senate on ensuring that all residents of the Commonwealth are receiving the highest quality care and deriving the most value from the healthcare system. Again, thanks for inviting me to testify. It's a pleasure to be here.
Thank you.
Keep going.
Angie, yes, please. Thank you.
Good afternoon. Sandra Fenwick. I'm the CEO of Boston Children's Hospital. As I think many of you know, we are a 415-bed pediatric academic medical center. We see about 24,000 admissions, about close to 700,000 specialty visits, and we have a network of primary care physicians all over the Commonwealth. We are committed to truly delivering value to children and their families. And we have been working very hard over the last several decades to do so, looking at quality, looking at safety, experience, and innovation across all of the dimensions of delivering care, but also in the area of really affordability and price. And we are also building and have been dedicated to building a distributed pediatric delivery system, both in Massachusetts, but more broadly across New England and beyond. We partner very closely with 11 community health centers, over 80 practices within our pediatric provider organization, but also with many of our colleagues here on the panel, both in primary care. We deliver primary care services literally across all aspects of the Commonwealth. In addition, we've been servicing community hospitals and attempting to deliver care in the community for children, enabling both inpatient, emergency, and NICU services in 7 community hospitals. And that's been going on for well over 2 decades. We also support many of the academic medical centers when they have high-end specialty needs, such as ICU coverage and other specialty cares, both in Boston, across the state, and now in all of the pediatric hospitals in New England. We've become a destination for the most complex and rare diseases in children. It has become an area that we have devoted both our largest pediatric research program in the world to addressing both complex disease, rare diseases, genetic diseases, but also all of the issues that impact children, social determinants at the community level, as well as all the issues that impact children's health. And last but not least, just a shout out for the difference in treating children versus treating adults. I think all of you know children are not small adults. They have separate and very distinct diseases. Their care it requires very specialized, increasingly specialized services with specialized nurses, technicians, specialty physicians, and the like. And when children get sick, they principally get very sick. And we worked very hard to move as much as we could out of a place like the hospital at Boston Children's into the community and across the whole continuum and support the care delivery in home and in other settings. So thank you very much. I appreciate very much the opportunity not only to speak about our institution, but also on behalf of children. Thank you.
Thanks, Andrea. I'm Kim Holland. I'm the president and CEO of Signature Healthcare, an integrated physician group and hospital in the Gateway City of Brockton, Massachusetts.
The home of champions.
The home of champions it is. Our patients have been dramatically helped by great academic partners down at Brockton, B.I. Leahy for adult medicine, Boston Medical Center for the Medicaid ACO, and then Tufts Floating for children for our pediatric care. As a safety net, we are, in your words, at the crossroads. Difficult position to be as a safety net community hospital struggling. We have participated in per member per month population health for over 9 years, probably 10 or 11 years. We had difficult year this past year financially and are doing what I would consider de-risking our organization due to the population size and not doing well in 2 different Medicare programs. We have unrisked our organization except for the Medicaid ACO and one of the commercial plans. Though that is important to us, we have tried to keep our community programs and some really innovative things we've done with local employers and local agencies alive in spite of difficult budgets this past year. We've maintained those. Though the thing I'm most proud of as an organization and our team is most proud of is the work that you sponsored a number of years ago through the CHART grant to reduce injuries to patients and our employees. We have reduced patient safety events by over 80% and have maintained that over the years as a result of the work you granted us to work on culture of safety, and we reduced employee events over 90%. And those are both, I think, meaningful and important. I thank you for bringing a community representative from the safety nets to the table. I think we're an important part of healthcare. And David, I know you're about to ask questions in a minute, but I'm hoping y'all will ask questions to at least 4 additional areas that might not be on your list.
Okay.
One is the cost of waste in healthcare, and in particular the meaningful role that external stakeholders have in making that change happen, because I don't think it happens without it. The second is the need for capital in community hospitals, not only for TME budgets, but for what I think is totally unseen by the information is a crumbling infrastructure within community hospitals that you can't see in any of your numbers. The third is the need to engage employers in redesign, which hasn't come up yet, at least today, in the work. And the fourth one are the various ways we cross-subsidize the cost of health care in a community hospital, so that you remain aware of that. It goes counter to one of the significant recommendations in the report, and I'm worried about the impact that has on community hospitals.
Okay. At least one of those came up yesterday morning, so.
Good, thank you. And thank you for having the safety nets here.
Thank you. Dr. Klebanski?
Thank you. So I'm Ann Klebanski, and I'm the president and CEO of Partners Healthcare. I'm now in my 4th month of serving in this role, and I really am here representing 75,000 employees. They are working every day across our healthcare system to care for patients, to discover new cures and treatments. That is a very important part of our mission, and the delivery of those cures and treatments to all of the patients that we serve. We are investing in and are committed to improving the health of our local communities. As many of you know, prior to having this role, I was the Chief Academic Officer, very much involved in the research and education mission. And I think one of the most important things to bring here is I've also been and remain a practicing clinician. And when I say I'm here representing the 75,000 employees, that is true, but most importantly, it is the patient who needs to be at the center of our considerations. And in many of the discussions that I've had, the patient voice is often not the voice that carries the most weight. So I think as a healthcare system, we are looking and are committed to having that patient care and the voice of the patient really be infused and really be at the center of an academic healthcare system going forward. We are a healthcare system with 2 very large, complex academic medical hospitals. They are renowned throughout the world. We take great pride in them. They provide care to very complex patients who come to us. It's important to note that about 1 in 6 patients are actually transferred to us from local community hospitals, specialty hospitals. This is who we are. We are also a set of community hospitals. And I would second that comment that Kim made about the difficulties in community hospitals, whether they're in your healthcare system or not, the infrastructure needs. We have invested, as you know, a significant amount of money in many of our hospitals. Spalding, North Shore, I want to highlight for a reason that I'll get to in a minute. We are really committed to delivering the care in all these spheres, in complex care, in primary and secondary care, specialty care. Where we deliver care is a very important part of our strategy going forward. So there is care that needs to be delivered at all these places, but how we move people to the right place to get the right care at a price that makes sense, that is really one of the most important things we're working on. And that can involve things like the medical home that we all have been talking about, the ambulatory strategy that many of us are doing to deliver care outside. I would just highlight two, I think, important things, and it really, I think, very much is consistent with what I am very pleased to see in the proposed legislation going forward. Number one is that one of the major challenges that we have as a healthcare system is behavioral health. Access to behavioral health and the split between thinking about behavioral health and health in terms of care provision and in terms of funding is a fundamental problem that we are faced. Many, many of our patients in all of the settings that we take care of patients have either behavioral health needs that are unmet or comorbidities that really need to be looked at. So our work to integrate behavioral health into primary care and work that needs to be done to use modern technologies, telehealth, to really expand the reach of that, I can't emphasize that enough as really important things to do. As you know, at North Shore Medical Center, we've now invested over $200 million in setting up the Epstein Center for Behavioral Health. It's the largest inpatient facility across the Commonwealth. It's about 125 beds. But I would just say that it's just the beginning of a much, much, much larger thinking process that we need to do together about what we're going to do to take care of those patients. I think the final thing that I would just highlight is that the concept of technology to provide health is something that we all talk about. There is very little funding to enable us to do that. So we do that piecemeal. We do not do that in a way that really serves our patients. If you look at the advances in technology and what that can promise for healthcare delivery, and you look at how we actually do that and how we are paid to do that within our healthcare system, the divide is actually enormous. This is something we have to work on together. If I look at one program, which is just telehealth, telestroke in neurology at Mass General, there are actually millions of patients you can touch locally, regionally, and around the country by having integrated paradigms, by using paradigms to enable care to be delivered effectively. These are the things we really need to focus on. So I'll just conclude by saying we have a very complex healthcare system that touches on all of the many things that are going to come up today, and I appreciate the opportunity to talk to you about it. Thank you.
Thank you. Dr. Strongwater.
Good afternoon, everybody, and thank you for the opportunity to join you today. I compliment the people who put the program together and agree with so many of the critical points that have been raised, particularly about behavioral health and primary care. So many of you know that I'm the president and CEO of the largest independent not-for-profit physician practice in New England. We have 715 physicians taking care of 745,000 patients. We have an integrated VNA, and we are committed to transforming care to improve lives. What's somewhat unique about our practice is at the moment, with the conversion of our Blue Cross Blue Shield PPO members, we now have more than close to 85% of our members, patients, in full risk arrangements or global budgets. So we wake up every day for all classes of patients, Medicare, Medicaid, and commercial lives, trying to figure out how to lower total cost of care. So the discussions in the last few days about moving everybody into alternative payment models is really very interesting to me. I think how we are paid in many ways defines how we practice and where we commit our resources. I would also say it's probably not sufficient there are some inherent barriers that make it very hard for us to practice. I'll use one example. We have been uninvited for having our case managers and EDs across the system so that we could prevent hospitalizations and move people to alternative sites of care. We believe that more patients could and perhaps should be moved directly from larger teaching hospitals to community hospitals. We've seen examples of that, both in the partner system and the BI system, but we believe it's possible to do a lot more. We have watched programs like Kaiser Permanente where they literally do repatriate patients from one place to another. We think that would help revitalize some of the community hospitals and have patients closer to their own homes. We think that would be an extraordinary help. We believe that price does matter, to come back to quote Stuart Altman, and that unless there are some price controls, it's going to be extremely difficult, even in a full risk environment, to manage down the total cost of care. And that includes not only on the hospital and other systems, but on the pharma side. We strongly support site-neutral payments. We think that would be a great advance. We know that people have tried in this administration to get there. We encourage you to keep working at it. We think that's really, really important. We also commend the various components of the governor's proposed proposal, not only about primary care and behavioral health, but touching so many other critical elements that we've all known about for a long time. And just laying it out there for everybody to see and debate feels really like the right thing to do. We also know that it is possible to lower the total cost of care. We absolutely know it can be done. And one of the things that's not popular to be said is that patients really want choice. That is kind of an inbred part of our personality in this country. But choice is not all that it's cracked up to be. What you want is an integrated, coordinated system of care so that people move through the system without waste and with tight integration, so there's high degrees of safety. So if you can eliminate the waste that we heard about and improve the safety and quality of care through standardization and reducing unjustified variation, you really can lower total cost of care. It is possible to be done. So I thank you for the opportunity to participate with this esteemed panel and look forward to the discussion.
Thank you. Dr. Tabb.
Great, thank you. Good afternoon, and thank you to the entire commission for convening us here this afternoon. My name's Kevin Tabb, and I'm the president and CEO of Beth Israel Lahey Health. I guess I'm the only one who, David, took you at your word that you didn't want us to make opening statements, but I will. Let me just state briefly that.
I think there was some filibustering going on.
No. I would say, first of all, that I agree with many of the statements that have been made by my fellow panelists here. We ourselves are partners with 4 of the 5 folks here on this panel. In fact, all 5, if you take into account the research that we do together. We were formed 236 days ago, but who's counting? And we were formed to do many of the things that have been talked about here, to provide a great care wherever patients need it at a lower cost and in a more efficient fashion. And as you all know, because you were involved in some of looking at whether we should be created, we committed to doing many of the things that are important to all of you, issues that have been raised by the governor in the bill that he put forward, and we are working urgently to make sure that those things happen, and we know that all of you are following what we do closely. We're looking forward to actually delivering on the promises that we made in the coming years.
Thank you all. I'm going to start off the questioning, and then we're going to all my colleagues will join in. So I want to sort of lay the groundwork, I think, for what is likely to be some of the questions, which is to say that speaking for myself and probably for a number of the other commissioners, we feel a lot of frustration. And the reason why we're frustrated is because the costs of medical care keep going up in the Commonwealth, albeit at a much slower rate, but they keep going up in the Commonwealth. And the quality is, overall, Massachusetts has excellent quality, but it's not sort of getting better in the way that we had hoped it would get better. So if you look at the writings of the famous Dr. Berwick, they would talk about how we should be able to get higher quality and lower cost, and we're not seeing movement in that area rapidly enough. And so that frustrates a lot of us. So you're talking about where's the money for investment in things, and the answer is the money for investment is in the institutions that keep getting more expensive, and then we can't come up with any other money for it. So my suspicion is that a lot of the questions for you are going to revolve around that. So I want to start off then with a very factual question, a very specific question, which is, almost all of you have come before us with things where you wanted to consolidate and get bigger in some way. And you said it would be good for the patients. And more or less, you said it would be good for the patients on one of two grounds. Either the costs would fall or the quality would improve. So what I'd like you to do, and we're now engaged in starting to do a retrospective on things that we reviewed, what did we think of them, and how did they turn out. So what I'd like to do, and I'll go the other way down the line this time, is say not speculatively in the future, but if you look at what your organization has done in the past, point me to a very specific thing that we could evaluate and say, did the costs to the people of Massachusetts fall? Did the quality of care rise? Did both occur? Like, what's a very specific thing we could look at to learn that?
Great. Thank you. I'll kick it off. I'd say, 236 days in, it may be a little early to do a retrospective, but Beth Israel Lahey Health has already taken and is taking a number of concrete and specific steps to help moderate the cost of healthcare and improve quality. And those, it began with the landmark 7-year commitment to price constraints that you are all well aware of under the agreement with the Attorney General, and the commitment that we made to manage total medical expense as part of our Department of Public Health conditions. Specifically, we're also pursuing a number of broader initiatives. Let me lay out 3. The first is the shifting of care to more cost-effective settings. There were sites within what were legacy systems before we came together that were very good at this, and there were others that were not as good at it. We've built off of the experience and best practices within the system to create almost immediately off the bat a virtual transfer center between the academic medical centers and the community hospitals, so that in the past, any inbound request to one of the academic medical centers was either accepted or diverted to another tertiary care center. That's not happening now, and we're measuring that on a daily basis. And we've seen tens of patients that would have in the past been diverted to more expensive tertiary care centers now placed in more appropriate community settings as a result of setting this up. The second is reducing avoidable use of the emergency departments. So we've expanded urgent care with some of our existing centers in Chelsea and Chestnut Hill and Danvers and Gloucester and Linfield and Wilmington and Woburn and a new site in Quincy. We've expanded walk-in and same-day PCP appointment access, bringing all of our primary care in the space of less than 100 days into a single organization. We've done things like we now have immediate access to a centralized nurse triage program for all the patients across the entire system for after hours and weekends. And then lastly, the third is, I say, we are making a monumental investment in primary care and behavioral health. We're implementing the collaborative care model across all of our employed primary care practices. There's plenty of evidence, plenty of peer-reviewed studies that this model reduces TME. By the end of this year, by the end of FY20, we'll have implemented the model in approximately 20 additional practices, serving an additional 100,000 patients. And over a 3-year period, the goal is to implement the model in all of our employed practices, serving an incremental 500,000 patients that would not otherwise be served. So I think that those are very specific answers to your question.
You only want one.
I only wanted 1 and I got 3.
Yeah.
But those are all things we could look at, and so thank you.
So David, we have, we don't own hospitals, so it's hard for me to give you the same answer. We have had, we are one of the only systems that have had health status adjusted total cost of care go down in all 3 major commercial payers. That's the HBC report. We have been the lowest use ED in the state and the Commonwealth. And we have a series of programs that we think will push the envelope in lowering total cost of care that are new. Hospitalization at home with a company called Medically Home as an example that we really just have started getting off the ground and just started to use for our Medicare. And when with all the contracts, hopefully with Medicare Advantage and then with our commercial population, we believe that we can move 15 to 30% of routine hospitalizations out of hospitals, brick and mortar, and into the home to be cared for. We've put in place programs like Care in Place, while bridging till the paramedic regs for mobile integrated health were available to again avoid hospitalizations. We hope that as the paramedic use improves, that there will be a greater triage opportunity around patients before they even get to the door.
Just to be clear, the fact is on health status adjusted TME,
Yes, health status adjusted TME.
and there's probably a bunch of that, which is the health status component rising rapidly, because that's rising rapidly in every system. On a non-health status adjusted.
I don't know the
metric.
data,
Okay.
unless you do, David.
Not off the top of my head.
Yeah. I think the issue, well, yes, I'm not going to discuss that with you, Dave.
It's an issue the commission has been concerned with, which is that the population of Massachusetts seems like it's getting astronomically sick year by year, so much so that none of us should actually be around.
Yeah, so we live with the reality of the costs all around us.
Yeah.
And we're compared in a like way to
Yeah.
everyone else.
Yeah.
So on that basis, I would say we've been making some progress. Admittedly, we believe there's a lot more that can be done.
Dr. Klebanski.
So I'm going to make a few comments. Number one is just to say what I said before and to emphasize what everyone is working on, which is moving care into the appropriate setting, and that is moving care out of the AMCs to the community. But I would push it a little bit further. It's not just to the community hospitals, but it's also ambulatory sites. And ambulatory sites can be those hospital licensed sites, but it can also be freestanding sites that are not on the hospital license. So one of the initiatives that we're moving forward with is to set up these ambulatory sites in the communities that will deliver care, whether it's surgical care, whether it's primary care, integration of behavioral health into care, and largely tailored around what the needs of those communities are. Second point I'd make is transferring patients from the AMCs is always talked about. One of the advantages of having hospitals, community hospitals within your network, as well as ambulatory sites, is it's easier to set up the paths of doing that. So for example, at Faulkner Hospital, there are plans from the Brigham, it's called Faulkner 21, which is basically moving out a certain number of patients that are at the Brigham to the Faulkner every week. There are very similar programs that are either there or being developed with MGH and Newton Wellesley Hospital. So I guess the 2 points I'd make is number one, and this gets to, I think, what your original question was in terms of owning hospitals and what's the benefit or not of it. I think the first thing is that when you think about this, there's capital that can be put into hospitals that you own. We do that all the time with our community hospitals. I've already mentioned the work that we're doing at North Shore, but it really enables to have a full spectrum continuum of care system where you can really move patients where they need to be and where they need to get care closest to the home. The other thing, which I think your question brought up, if just to take a minute on that, is what's the advantage when you actually acquire a hospital? Because there's been a lot of discussions about that, and rightly so, over the years. And the one point I think I would mention is when MGH and Partners acquired Cooley Dickinson, that's a small, as you know, community hospital in Northampton. There were a number of ways in which the hospital really benefited from that. One was there were some rather acute issues related to OB, GYN there, and we could bring in a team to really work with that and improve patient outcomes, quality and safety, and those standards could be adhered to. Bringing in Epic or any other electronic medical record and really having that seamlessly integrated into care for patients who are being seen in many different parts of a system, that's also a really important thing that comes when you actually acquire these hospitals. So in terms of many aspects, we've certainly seen the benefits of that. So I don't know where that's where you're going with your
Just-
question,
no,
but
no,
I
so
think
just to be
touch
clear,
on
we
that.
should be able to see quality improvements, say, at Cooley Dickinson. And we
Yes.
should be able to see more partners' patients admitted to community hospitals and community settings when we look in the data.
Absolutely.
Okay.
And I think part of that is what's the trajectory, how quickly is that happening, and what are the things that we're doing to make sure that continues to happen at a more rapid rate to get to the point that you're getting at, which is where's the patient going to be seen to get the best service they need, to get the best treatment they need at the lowest cost.
David, if I was here looking to expand, I didn't recognize myself. We've taken a position at Signature that nobody understands gateway cities other than people that live and work in gateway cities. And we've taken a position that we will stay independent, and we believe we can better meet the needs of our community by maximizing the value from academic medical centers and then staying independent. It's a difficult road for us to do, but we believe that better serves our own individual community. Having worked most of my career in systems, as you probably know, systems either will maximize the value to the system or they will maximize the value to the communities, but they cannot do both because both are not possible. We've taken the position that we'll maximize the value to our community by staying independent. Now, that said, one that I would say you could add is oncology and orthopedics for the Brockton community. Our partnership with Beth Israel has really transformed both of those services, particularly in oncology. The quality of care we're able to deliver is as close to academic level as it could get in a tremendous partnership with BI. And I think we've transformed what I think was community medicine oncology in our local area, and it's growing like weeds and doing really well. And the same with orthopedics. And it's the collaboration with BI that's made a difference that we've been able to recruit better physicians. In the last comment, I would say, I'm glad you're going to look at quality, because here's my window of entry into the issue. As I look at quality in the state of Massachusetts, I don't think it's actually that good. It's better than other states, but it's not great. And because we have tremendous research, we want to say it's great, but it's not that great. As I look at just one measure, Leapfrog, and just you look at it because it's simplistic, Leapfrog scores in the state of Massachusetts haven't really changed for the last several years. If you go back 4 years, you'll see about 50% of the hospitals in the state with a Leapfrog score of A. You'll see it's the same in the last survey. You look for 5 years, you'll see the same, about 50%. You'll see it doesn't seem to vary by system or non-system. So I hope you do take a close look at good quality measures over not a 1 year, but over a sustained period of time.
Well, you asked, Professor, for one example of each. I don't think it's possible to give you sort of one example, because I think this is an effort. First of all, it's a journey. I think it's a multi-year effort, and I think it is an effort of looking at many, many, many contributors to both quality and cost. And I think that that's where we've, over the last, at least the last decade, we've looked at the question of both unit cost and utilization, because those are the two cost drivers as we truly understand them. On the unit cost side, we've worked very hard to try and take unit cost out of the hospital and out of all of our settings and practices. And that's been a journey that we've been working very hard on, and we can give lots of examples on that. Because that's something we track. It's a corporate goal. It's something we've been doing for every single year over the last 10 years. And it continues to be, and I think it will be forever. And then there's the utilization piece, and I think that's something where you have to look at every single thing you do. And so a move from every setting, from ICU to inpatient, inpatient to outpatient, outpatient, all the way down the continuum to eventually primary care, community health center, home, is something that we have had over 200 projects on over the last decade. And we've made enormous progress of moving what used to go to the ICUs, go from the ORs, to, like with spinal surgeries and some of the transplants, going straight to beds. And so every step along the way, you have to break this down and really look at every component and see if you can actually change that. We have everything we've done from, children who require anesthesia for MRs. The children who get MRs in an adult setting across the country, about 80% of them age 3 to 7 or 3 to 10 have anesthesia. In children's hospitals, that's about 35 to 40%. We've gotten it down to 15%. And so those are kinds of projects that you work on, and you just accumulate each one of those to try and move the dial. We've done that with the relationship we have, as I mentioned earlier in my opening statements, about trying to move as much as we can into the community setting. With emergency unit coverage now in 7 community hospitals, they are now doing nearly 70,000 emergency unit visits to our under 60,000. So we've been really trying to keep the balance of where care can be delivered in the community. And those are just different examples. On the quality side, I think the question is, what do you mean by quality? Because that's another complex question. Is it outcomes? Is it any of the STEEP components? Is it equity? Is it safety? And I think one needs to be working, again, on every single aspect of trying to work on those aspects of quality. On the safety side, as Kim, you mentioned, we've been founders of an organization called the Solutions for Patient Safety in Pediatrics. There are now 120 children's hospitals that are all sharing data, have a commitment to reduce hospital-acquired conditions of 25 to 40%. We're at it. We're making progress. Hundreds of thousands, millions, billions of dollars are being saved through those efforts, and I sit on that board, and we're a major leader. Tomorrow we have a board meeting, and we're going to be shouted out at Boston Children's for our progress. So that's one aspect. Outcomes, also, we need to, when we think about outcomes, we need to think about them as it relates to children. And I think those places where we've been trying to benchmark, we've created registries, we've created ways of really saying, can you not only look at reducing costs, reducing utilization, but maintaining or improving outcomes, actual clinical outcomes, quality of life measures, experience, and all of those components. And I think that's something that I welcome any one of the commissioners to come in and sit down and look at some of the results across all those dimensions. And last but not least, I think on the issue of cost, the question is, what's the right comparator there? As you notice, we were not up there with one of the delivery systems because children and children's costs are difficult. We benchmark ourselves against the 30 other independent children's hospitals across the country, and we are in the bottom quartile of both reimbursement and cost of all those 30 children. And we've been down there now for the last 7 years. So I think that's what we've been trying to do, to say, are we staying true to the commitment, and are we really able to demonstrate to ourselves that we're making progress? Thank you.
Tom, if you merge with HPHC, your premiums are going to fall?
Well, I was waiting for a different spin on the question, since we obviously don't own hospitals or deliver care. I mean, I will say that when we look at provider consolidation, the first question that comes to our mind, because we represent our customers, is what impact will this have on cost? And the results are always a bit confusing at best. As we look toward a consolidation of 2 health plans here in this market, we would expect to be held to the same standard. We should, one of the primary goals of the combination would be to bend the cost curve. We obviously cannot stop medical cost increases, but we think we can have a very real impact on the cost curve going forward. And the pharmaceutical area is a good example of that. The 2 organizations today have separate PBM contracts. We think there's a good opportunity by combining our buying power between the 2 companies to secure better terms and lower prices for pharmaceuticals. Certainly from an administrative cost standpoint, there are synergies that can be derived from the 2 organizations that will translate to lower operating costs that need to be built into the premiums that we charge. I would point out that certainly from our viewpoint, we operate in a heavily regulated and pretty transparent world today. Our insurance products and services are subject to filing requirements and approval processes. We have minimum loss ratio requirements in the merged market in particular, limits on how much admin expenses can be built into premiums on an ongoing basis. There are caps on what can be built into our premiums from a profit standpoint. So certainly, again, we share the goals of trying to improve cost and quality and would expect to be held to the same standards. And we think that's actually kind of a natural part of the regulatory review process as we go forward. In terms of what we can do to help others manage cost and quality, I mean, I see our role as a health plan as being obviously a bit more secondary. I would just highlight two things that I think we've seen some reasonable success over the years, and that's in working with value-based payment arrangements with providers, which are really designed to accomplish the goals that we're talking about here: reduce costs and minimize cost increases and improve quality. We've been operating in that kind of environment for our Medicare Advantage business for more than 25 years. The Medicaid ACO program is really oriented around the same goals, and we're pleased with the progress we've made in helping those partnerships emerge. So that's one area where I think we have shown some success. The second is in offering products that incent the right kind of behavior. So tiered and limited network products are the good example. It's been kind of a tough slog, particularly employer market, to secure acceptance and widespread adoption of these kinds of plan designs. But where it has occurred, we've actually seen some pretty notable successes. If I look at the utilization of providers in the first tier of our tiered products, back a few years, it was in the mid 50% range. Now it's over 70%. So I think that's progress. Is it a solution? No, but it's progress.
Let me get a list then of which of my colleagues. So we'll start off with Ron and then Chris.
Thank you for joining us today. We really appreciate it. I just want to first make a comment and ask a quick question, and it sort of relates to what David had brought up earlier about just healthcare costs in general not rising as quickly as it had in the past, which is an accurate statement. But if you compare it to U.S. inflation and then look at healthcare price increases versus U.S. inflation since the recession in 2008, your costs have gone up significantly more than historically as it compares to inflation, which is interesting, right? In terms of consolidations, and I'm hoping after we as a group did quite a bit of work with Kevin that that organization is not going to fall into what we've seen nationally historically, where costs have gone up, and I don't know how quality can be truly defined, but whatever you read, quality has not increased in those areas, according to studies that have been done. I'm hoping here in Massachusetts that won't be the case. But then, Tom, you had mentioned in your opening statement that you supported many of the provisions of Governor Baker's bill, which really leads to my question. What provisions don't you support? And I'd be really interested if we could go down the line just to get what I'm sure all of you have analyzed it, right? What don't you like about the governor's proposal?
Mary Lou is still in the room, folks.
You want me to?
We'll start with you.
Would you like me to start? I'm not sure there's anything that we don't like. We need some more time to study and think about the implications. I think, I think that the effort is focused on the right areas, and many of the actions that the governor has proposed are things that we've advocated for a long time.
What's the most important provision then that you believe is in the bill?
I think controls over pharmaceutical prices is really an important element. because that's not something that we've been able to address successfully on just with private sector efforts. So I certainly would highlight that. I think the focus and investment on primary care and behavioral care, I think, is entirely appropriate as well. I think the trick there will be to do it, achieve the kind of increase that we're talking about in the context of the existing cost benchmark.
Is there a downside from your business perspective?
A downside to the,
Bill?
I think it would get to execution details that again, we're looking forward to working with the administration, with the House and the Senate on better understanding how each of the provisions would work and work through that.
Can I just ask a question related to Ron's? At any of your organizations, do you foresee any time in the next 5 years where the costs of medical care on a per patient basis or per member basis will decline?
David, in some ways, as a safety net, because we rely on the government heavily for our payments, 75% of our payments come from the government, and we're the 10th lowest paid hospital in the state. We've had a goal in our organization of reducing our per click cost by 2% year over year for the last 3 years, trying to get underneath the reimbursement curve that we have. We've been successful doing that. It hasn't always been at 2%. And we've been successful reducing total medical expense. We're underneath the state by 4% on Medicaid and had been doing a very good job in Medicare and bundles.
So that's one yes.
You know, I'd say, first of all, we've committed to something different than what you asked, which is to stay under our cap in terms of the growth. But you asked, is there going to be a decrease in cost? And, I'd say the rise in healthcare spending's multifactorial at best. But if I simplify it, it's divided into two major pieces: costs that are within our control, us as providers in this case, and costs that are outside of our control. We, as providers, absolutely have to be part of the solution and take responsibility for those things that are in our control. And there are many things that are in our control, and we're going to have to do better at it. We've committed to those things, and yes, we are working actively, and we're being tracked on those things to reduce those costs. But it's impossible to have this conversation without also acknowledging that there's a fair number of costs outside of our control.
Yeah, let me leave out the pharma for this.
But it's it's pharmaceutical spend, it's labor costs, it's new technology, it's all of those things. I wouldn't come forward and say those are the only issues, but it's impossible to just leave that out and say, is the cost going to go down? Because those are significant components also. So I acknowledge that we absolutely have to do work on the things that are within our control, but many of those things are not in our control. And in conjunction with the work that we do, we'd like to also see help on those other things that are outside of our control.
We did have a specific question. Are there any objections to any elements within the governor's bill? It sounds like there might not be. Oh, there is.
There might be.
You want to?
Go ahead.
No, I wouldn't call it an objection at all. I think that the work is the clarification in terms of what a lot of these mean. And I can't emphasize that enough. So for example, as a healthcare system, we have already invested very heavily in behavioral health and in primary care. And those are investments that we have made, that we are going to continue to make. And I think part of the challenge for us as an organization, and it really relates to this too, is definitions. The definition of behavioral health is very, very broad. And within the context of patient care, it goes from the most ill psychiatric patients to patients in a primary care setting who may need to be screened for depression or use one of our online CBT tools. It involves patients who need to see psychiatrists or psychologists, but then the whole other array of healthcare providers or peer counselors who can really provide help in this whole arena. And whether it's an in-person service, a telehealth service, an online self-service, these are just very, very important components to just highlight in a very complex issue. So I would say that for many of these, and that certainly includes primary care and behavioral health, it's going to be a definition of what that really means. What are the services provided, and what does that really look like?
So definition, execution, not necessarily
Definition, execution.
a single element that is.
Absolutely,
Okay.
at least to me, I
And
think
Kim,
those
you
are the
had
important
you
things.
had one pick?
I read so many things getting ready for this. I believe one of my concerns is in the bill, but I'm not positive. But there are two that do worry me. One is, as strange as it might be, increased payments for primary care. Safety nets work in a very brittle economic structure, and we're not there alone taking care of people with low socioeconomic means. But we have physician groups that are independent, that are very large, on our doorsteps that take mostly commercial pay, small amount of Medicare, and almost no Medicaid. Yet we compete with those groups for being able to hire and retain physicians to take care of the poor. If they get a 30% increase in payments through commercial, we totally destabilize. I'm not sure I know how we continue to provide access to care. We take money out of the hospital to provide access every year. That destabilization would be critical to the safety net. So maybe that's a definition of the how, but it's extremely important to us. And then there's another, I think, in here, issues about facility fees around hospital departments. And again, it's an eco-structure issue for us. When we have a hospital department, we're using those facility fees to pay for the difference between Medicaid reimbursement and commercial reimbursement. For a 99213, Medicare pays us $39, commercial pays us $100. Where's the rest come from if you're able to hire and retain a physician? It comes out of the pockets of the hospital. Where's the pockets of the hospital? Facility fees. And the governor's bill aims at those facility fees. And then the last is site neutral. I think the bill has site neutral language in it, or it was either HPCs. I'd be okay with site neutral payments if it was neutral to site. Appropriate laugh, but it's never neutral to site, because we actually provide care for Medicaid, Medicare people regardless of their ability to pay. We have an emergency room. We provide access to care. We're using the dollars from radiology to be able to do that. But freestanding radiology centers do none of that.
Okay,
And so it's not
let's
neutral to me.
pick up on David Cutler's points about both frustration and about potentially reducing costs. And I'll go to Steve Strongwater, because Steve, you said, you mentioned medically home and acute care at home and said, 15 to 25% of costs could be taken out. And I presume this is the medical patients, cellulitis, failure to thrive, FUO, CHF, COPD, and so on. And you've just started. How many patients have been diverted from emergency rooms?
I wish I could give you an accurate number. It's well north of 100.
Okay, so what'll it be a year from now?
Well, I have a long-term target of thousands.
Okay, that's good. We like those. That's great. Now, what are the barriers to making that happen? So, where's the resistance to what is? It's been who's the guy in Maryland? Bruce Leff.
Right.
25 years ago, started publishing the studies here, and it hasn't happened because I think the status quo, resists it. But can you talk a little bit about what barriers you've seen with motivated patients and motivated doctors to not put somebody in the hospital, but once a home is qualified, caregiver and nurse coming in and so on. What are the barriers? Are there regulatory barriers? Are there hospital CFO barriers? Are there?
Well, quite ironically, the first hurdle was getting approval to be paid. Because this is really care that's equivalent to an inpatient setting, but it's done at home, so there are no codes to do that. And there's an extensive use of telehealth, and there were no codes to do that by multiple payers. And so working through those logistics have been sort of the first part of this. I'd say because it's relatively new in this community, getting referrals and sort of patient acquisition is has been another issue that we've been working on. Getting approval through the regulators, through the Medicare Advantage plans in particular, as Tom will know, because we did a pilot, we started a pilot with Tufts Medicare Preferred, was another hurdle. They needed to have it built into their plan design. And once you get approval from each of the payers, then I think it is about patient accrual and patient acceptance. But it can be done. I would say that we've reached the tipping point in the context of having technology not be the barrier. It is possible to put a patch on a patient and get the kind of monitoring that you get almost in the ICU. And by virtue of setting up admission control, getting real-time vital signs, and you can lift up a phone or touch an iPad and get right to a physician. So those barriers are no longer in place. So we really believe we can disrupt care. By the way, we think it could apply to surgical care as well, by virtue of taking patients who would normally be recovered in the hospital and just recover them at home. So maybe even have their surgery in an ambulatory surgery center and then recover those patients directly at home, avoiding a hospital entirely.
So it sounds like a lot of the barriers have been removed. And potentially Ann and Kevin could reduce 10% of their beds in the next few years. Is that plausible, Ann, Kevin?
So I would say that you mentioned the barriers, and it also gets into applauding the defining and expanded access to telemedicine in the bill. I want to just single that out as a really, really important component. So let me just give you one example of something. So several weeks ago, I went out to a Partners Continuing Care home visit. So I went out there with a nurse. We went to a family, and this was an elderly patient with diabetes and his wife. This is a patient who would come in and out of the hospital for hospitalizations all the time, primarily due to infection. Okay, so this is a typical scenario that we see. So this whole visit for this nurse, because I was with her the whole time, really took several hours. She had to get out there, she had to get the records, she had to meet with the family. But here's the important thing. Because of technology, she was able to take a picture of the wound, immediately send it to the doctor, who immediately came back looking at this, saying, this is what you need to do for treatment. This is going to be the plan. And you know, frankly, if that hadn't happened and nothing had happened, that patient undoubtedly would have come back to the hospital. So I saw it firsthand. It was really impressive. And as we always say, how scalable is that? You know, how do you get to that 10% that you're talking about? So the challenges here are several. One is identification of patients. We are working very hard to identify those patients before they come in, when they're in the hospital. So that's something I think we all are working on, to really identify those patients, set up the right connections. There's also patient preference. There are a number of patients who will just come to an emergency department no matter what's coming on. That may be the patient, that may be their family, but we just have to acknowledge that despite all attempts, that's going to happen too. So I would just say that this is being worked on. I can't tell you about the 10%. I think consistent with how we look at telehealth and those technologies and reimburse for them, that's going to make a significant dent in programs we're already seeing.
Can I just put in a plug for looking at reimbursement for home care providers? They are not well compensated, and they have very high turnover rates.
Yes.
And stabilizing that part of the delivery system might help to avoid returns to the ED.
I want to come back to one point, because I think Kim said, oh yes, I actually lower my costs on a per patient basis. And 3 of your colleagues at the table also run hospitals, and they didn't agree that they lower their costs on a per patient basis. So give them some advice. How can they lower their cost on a per patient basis? What do you do to lower your cost on a, give us some advice.
Well, from my perspective, you start 8 years ago implementing Toyota's management system called Lean and Operational Excellence, and you take waste out of the system. And then you become much higher quality, and you take additional patient harm out of the system. And from taking waste out of the system for 8 years, year after year after year after year after year after year, you actually can become more efficient over time. We've focused singularly on safety and quality, believing that would drive finance. And we run our organization close to operational excellence as you can. And I think it's made a difference over
So
time.
if we put you in charge of Partners Healthcare and Eli Leahy
I'm
and
not
Boston
leaving the
Children's,
safety nets.
would costs fall? If they did what you did, would costs fall?
I can't help but say, focusing on patient quality and safety, operational excellence, daily management systems, which are not taught in healthcare leadership. We're not doing it in healthcare leadership as much as we could. It will help cost fall. I don't know what percent, but I do believe there's internal waste in our systems that could be taken out.
Let me go to Tim and then Don.
You want to?
Oh, I'm sorry.
No, the only point I was going to make is I was going to agree with the importance of looking at efficiencies and internal waste. And as you know, we started 5 years ago on this Partners 2.0 5-year plan to take out $500 million in operating costs from the system. We're in the third year. We're about $375 million in. So there are ways to do that. But I just want to make
But the
one
spending
point.
is still going up rapidly, right?
Yeah, I'm sorry?
Partner spending is still going up
Yeah,
about 3%.
and the thing I just want to make 2 quick points, which is that we have an incredible workforce. This is the workforce that really delivers the kind of care and frankly works on providing the kind of cures that patients come to us for. And it is hard to keep that workforce in Massachusetts, and it's just a challenge. So I just want to put that out there as a challenge that we all face. And the other thing is, again, the incredible complexity of patients we see, where 1 out of 6 patients are coming to us from other specialty hospitals and community hospitals within the state. That's just a reality. So I welcome these suggestions, and we're of course happy to work on these problems together. They're just not simple, and you know that.
Thanks. Last 2 speakers saying we need to invest in our workforce in order to make sure we can retain quality staff is really important, so I appreciate those 2 comments. I just wanted to, I think, particularly now we're kind of almost nearing the end of the couple days of our cost trends hearings, and particularly with this panel, just pull back for 1 second and take a bigger look at what we've been reviewing and thinking about, and as we look at the cost trends for the past year, and just writing down a few things that were popping in my mind. APM stagnant, community appropriate care stagnant. That's going to AMCs. Pharmaceutical spending's up, prices up, utilization down, retention of premium rates are up, administrative costs up, readmission rates stagnant, ER utilization increasing. Risk scores are increasing, and consumers are the ones bearing the cost of all of this in the system. So I guess my question is, as we are looking, just taking a bigger picture here, where do you see good news in the cost trends report that we've just been reviewing and discussing for the past 2 days?
Wow.
And there's the answer.
I just think we have to keep at it, because I think these are, to some extent, micro efforts that have to accumulate to continue to work on because as we look, especially in pediatrics, we have such incredible variability in what comes in our door. It is a very different environment than even some of the major academic adult institutions. We've got a paper coming out soon that has been looking at this with, millions and millions of claims across the whole country and looking at children's hospitals versus some of the adult hospitals. The variability in what comes in our door to be able to try and standardize and reduce costs in every single one of those. We see approximately 275 different kinds of kids coming in every year to an adult hospital that might see 65. So trying to figure out how to work on every single one of those. Yes, I mean, we have an enterprise, a project management organization that is doing Lean, that is doing Six Sigma. They're all black belt people. We're working on all of those things as well. But it's also trying to figure out how do you address every one of those specific, sometimes N of one, sometimes unique patients that come in that you really need to work on individually. So it's a challenge to try and figure out how you do this across the whole board.
So, Tim, I guess I'll take the bait on it. I think you raise legitimate concerns, and I would suspect that every single person sitting at this table is as frustrated about it as you are. I'm going to choose to see a little silver lining in all of this and suggest that the things that you outlined are exactly the opportunities that are in front of us. And those systems that choose to see those things as opportunities and make significant changes in the way that they're structured and the way that they deliver care, different than the way that any of us have done it in the past, will make the difference and will ultimately be a great deal more successful, and our patients will be better for it. So I think, in essence, laying out those things is not any less frustrating for seeing them, but it's a roadmap for the things that each of us individually, each of our organizations individually, and maybe all of us collectively, have got to make real headway on. I know for our organization, you're measuring it, you're following it. So I'm planning on delivering on many, not all of those things. But I would also agree with Ann that these things are hard and very complex.
May I just add that it's worth celebrating that we made the trend, but it's also worth pointing out that we do not control healthcare costs, believe it or not. The vast majority of healthcare costs are driven by behavioral, by social determinants, by things that are literally out of the hands of the people who provide healthcare. And it has to be a partnership, I would argue, with the rest of government. Just take housing as an example, or food security. It can't be that healthcare owns all of that. We need to work with other parts of the broader system.
If I were just tag on, I'd agree with everything that's been said. I guess one thing I would characterize perhaps more as a promising development than evidence that things have necessarily gotten better. You mentioned APM, either stagnation, adoption, or even some decline. Even in the commercial population for Tufts Health Plan, that actually hasn't been the case. We've actually seen some growth. So we still think that there's some real headroom there in a positive development. With respect to the Mass Health ACO program, we're still very much in the early innings, but I do think restructuring the program to form this, an accountable care organization structure makes a lot more sense than just paying everything fee for service. So I think it's a step in the right direction. I think we need to continue working really hard on refining the program, and I know the Secretary and the entire administration is focused on that, but I think that is very much a positive move in the right direction.
First, Dr. Klebanski, and then I'm going to go to Dawn, and then Barbara, I'm going to come to you.
No, I just wanted to just highlight this ownership issue, because we talk about that a lot, which is who owns all of these problems. And it's often, just to say the obvious, it's a collective ownership. So to get to some of the points that were made from my colleagues about things that relate to social determinants of health and all of the other things that impact on these costs and total health expense, we really do have to work in partnership. We can't do it alone. And I will just take again the example of behavioral health. This is not a Partners Healthcare problem. It's not a Commonwealth of Massachusetts problem. It's a national problem and beyond. So if we try and think what we can do in our own individual hospitals or healthcare systems, partnering with others who are working toward the same goals, and that really is all of the goals that you've talked about. That's really the only way to step forward. So I would go on the silver lining sort of theme and saying what you're hearing are really positive steps going that have kept us where we need to be, and further progress really can only be made with that sort of collective thinking. And hopefully the bill will help get us there.
Dawn?
Well, I'm not sure I have anything new to add, but Tim's recitation is much on my mind. And the way I see it is this, that each of you is accountable to a board of directors that's holding you accountable for performance metrics. And those performance metrics have to do with the health and vitality of your own organization and the people you serve. And not just in every, I suspect in almost every case, not just your sustainability, but your growth. The math doesn't work. The math doesn't work. From the viewpoint of society as a whole, this is a failure. because we're taking money from all the things you just said we need to work on, like food security and housing and criminal justice and the things we should work on, and you're taking the money. So the silence when David asked this question, will you reduce cost, was really quite deafening. Because unless you do that, and I mean for real, I'm talking about not 3.1% increase per year, that's not cost reduction. That's cost increase at a multiple of the rate of inflation. So if the leaders of the prestigious organizations in this Commonwealth won't say, we will reduce our costs so the money can get back to things we need to do it, I don't see a solution. I'll be in England in 2 weeks. I'm not supposed to mention England if I'm before the U.S. Senate, but you know, I'm going to be sitting with the head of the National Health Service who says, I have a budget, this is the budget, and I got to figure out how to spend it. What should we do next? I was in Taiwan 3 weeks ago, same conversation with the Vice President of Taiwan about the aging. They're thinking about the system and the well-being of the system. You're not in terms of results. I'm not criticizing you as human beings. I'm no more ethical than you are, but we have no solution in this room until the leaders of the health system agree to free up resources that can then be used for other purposes. And Kevin, of course I understand, you know, you're the repair shop, you're fixing dented fenders and we have to repair the roads, but we can't do it if healthcare is confiscating the resources from the common pool. The problem with making that point, of course, is each of you is noble. You're trying to, who can criticize what Children's Hospital or partners are? You're all doing wonderful stuff, but you've got to do it differently or we don't have the latitude to invest where it needs to be invested. So I feel, as I always do, admiration for every one of your organizations, but enormous frustration that there's no partnership here to really solve the problem. That's how it feels to me.
Thank you. Actually, I want to build on Don, and no, we did not collaborate on how we were going to do this. But Steve, I appreciated your comments about a lot of the issues that drive your costs are not issues that the healthcare industry has direct access to managing or maintaining. But it plays out in increased costs, increased utilization. I wonder if the approach needn't be to reframe the issue so that when we talk about community health, we're talking about the community's health. And the community's health is not just healthcare. It's safe streets, it's playgrounds, it's good schools, it's no child going hungry to go to school, it's good daycare, it's adequate addiction services on demand. It is, in an urban setting, it's good transportation, there are transportation hubs. All of the things that urban planners talk about go into creating, I believe, healthy communities. You're at the brunt of the issue in that a lot of what happens when communities aren't healthy play out in your costs and your utilizations. You have a lot of skin in this game. So to build on Don's comment, what can you do as an industry, and how can you start to drive this conversation in that regard? What tables can you create? What tables can you come to and encourage all of us to come to so that we have that meaningful discussion and we demonstrate what the costs of not having healthy communities does not only to healthcare, but to all of us. The paradigm has to shift. The conversation has to be different. And how we assign responsibility needs to shift. Because we're not going to get much further than we've gotten now if we're not starting to have those broader discussions. So I just wonder if you'd reflect on that and help us think about it.
Well, I love what you said, because I'm a big advocate of healthy communities. We've been in communities for many, many years. That's who we are. We're not a single-site delivery system or even a multi-site delivery system. Geisinger took this on, that's where I was before I came here, and created a healthy community and food as pharmacy and housing security. And there definitely is an impact, I don't know the statistics off the top of my head, on improving total cost of care. And so I do think there is a place for that kind of integrated planning. And I believe you're seeing delivery systems making those commitments, contributing towards building housing and providing free food and the like. I don't think that the healthcare delivery system, certainly not our delivery system, has the bandwidth to do that. I do believe that some of the things that have been discussed, look at the Rhode Island experience, by investing in primary care can free up funds, the $88 million or whatnot, that Providence was able to free up by virtue of investing in primary care, which then could be rededicated and repurposed. I do think there are other things that could be required. I go back to regulation, I apologize, but in a PPO design that they're required to have a primary care provider, and that primary care provider could be incented in one way or another as a use of some of those funds. But I do think you're right that it has to be an integrated approach. I don't think no matter what we do here in designing our systems, unless we work on the other behavioral parts of the system broadly, that we're going to have the kind of massive impact on managing total cost of care. And it is a chicken and egg. I hear Don essentially laying that in front of us. I believe the governor's proposal of making that investment in primary care may get us out of the starting block, as it were, and be able to free up funds to be able to make those reinvestments.
I'm going to turn over to David Seltz in a second. My impression is that whenever we provide upfront money with the promise that we'll have back-end savings, that doesn't materialize. Whenever we provide upfront money but we require back-end savings, the savings materialize. So I think if we were going to rely on that strategy of let's do some of these investments, we would want to lock in the back-end savings as opposed to.
So one of the things that I heard from the Rhode Island experience was hospital price controls. So they're not independent. So that was not a zero-sum game. There were other tools that were activated concurrently to the investment.
Kim, did you want to?
Oh, I'm sorry, I didn't see you raise your hand.
As a key stakeholder, I think we've not talked about, so this is my way to get the fourth question asked that I still am tracking. We haven't talked about employers, and I think we have a role there. So you think about primary care. Primary care investment's really going to help. How many times a year does a primary care doctor see a patient with complex illness? Where's the dollars being spent? Top 3%. Top 3% are in those offices a lot, but that's not who we're really talking about that we're worried about 10 years from now. You're worried about the next 25% that have only one complex illness that are going to have 5 complex illnesses 10 years from now. Where are those people? Those people are working, most of them, because by the time they're Medicare, they already have multiple complex illnesses. Who sees them more frequently? Their employer. Where's the opportunity? I believe with employers. Not enough of them are self-funded, but if they are self-funded, they don't know how to dramatically change their insurance contracts to remove barriers to health care. Like, should somebody be paying a co-insurance or a deductible for diabetic medications and a glucometer if they have diabetes with the rates we have of people not taking their insulin? Well, that's a design issue and a behavioral economics issue that belongs in the hands of the employer, not the provider. And as a provider who does this for free and 25 employers are not up to this scale. They don't understand it well in gateway communities, how to do a better job of designing their healthcare. And I think that's a real opportunity because I believe that's where you can make a difference over a sustained period of time with nurse practitioners and employers working on complex illness and changing insurance design at the ground level, which we've totally left off the table. Thank you for asking.
I believe that counts as blaming the economist, but I'm not quite sure. David.
Well, I'll actually respond really quickly to that comment because Rick isn't here, and so I'll try to channel Rick. There is actually a coalition of employers that have come together. It's called the Massachusetts Employer Health Coalition. It was established less than a year ago. It's co-chaired by AIM and the Mass Taxpayers Foundation. Members include over 25 different chambers of commerce representing the vast majority of small and large businesses in the Commonwealth. And this coalition has come together to engage and help employers think about the right types of strategies to get their employees into the right care at the right place at the right time. And thinking about things around improving access to primary care, maybe reducing copays and doing benefit design, giving employees informational and educational materials about where to go seek the best value care. It's early, but this is an incredible platform that is being built that is going to get employers off of the sidelines and into this conversation. So encourage you to be connected to that. And I would note that Atrius has been a strong supporter of this effort as it's being beginning to build, and I think holds a lot of promise. That wasn't my question. My question is for Children's Partners and for Beth Israel. All three of your organizations talked about expanding care into the community. All three of your organizations are anchored by downtown Boston AMCs. Children's, Mass General, and Brigham are among the highest priced hospitals in the Commonwealth. Beth Israel a little bit more moderate, but growing. And I'd like to hear from each of you about, give us a little bit more insights about what is driving this decision to expand care into the community, and what are the considerations that you're making when you decide to do that, whether it's expanding services at Danvers or Foxborough or building new ambulatory sites. And I have two very specific questions. One is, when you're thinking about expanding care into the community, do you talk to the providers who are actually already serving patients in that community? And do you ever consider actually partnering with those providers as opposed to building or expanding new sites? And two, do you consider what the prices paid for services are in that community versus what your systems will be charging for prices in that community? My concern is that we'll see a migration of downtown prices to all of these communities, and how are you thinking about mitigating that concern specifically? So on both of those points, Dr. Tabby,
So good questions. I don't think that from our perspective that is in fact the history of what we've done. And I would suggest that in many of the cases of what was the legacy Beth Israel Deaconess system, we did exactly what you're asking about. We partnered with Signature Health. We partnered with Cambridge Health Alliance. We partnered with Lawrence General Hospital. And if you think about who knows most about how best to provide care in the community, is it people sitting in Boston or is it people sitting in the community? So I think that we have a track record of doing a lot of that, and we need to do more of it. In terms of why we would move care into the community, there are a number of reasons, starting with a simple one. At least at BIDMC, we are full. And what needs to happen is to make sure that the patients that don't come from that local area surrounding the medical center and don't need complex care get care out of the community so that we can take care of the complex patients. Now, I'm sure we will then get a concern about, well, your complexity is rising at the medical center. It will, and that will in fact be appropriate when that happens. So the first reason is we need to make room for the patients that can't or shouldn't get care elsewhere. And right now, on a daily basis, we turn patients away. So that's a problem. The second reason that we need to move patients to the community is the way that we provide care is changing. So whether as someone who runs a hospital, I like it or not, it doesn't really matter. More and more care can and will be provided in the community. The sooner that we recognize that and move towards either partnering with or providing that care, the better it will be. I think all of us who are running health systems, not running hospitals, have recognized that, and that's why we're doing it. I would lastly say I was asked a similar question in front of this panel 4 or 5 years ago. So I guess the questions are similar throughout. You know, what I said then, I'd stand behind today. If you, as a system, any of us, if we sit here and suggest to you that we're going to move care to lower cost sites of care that we don't have within our network, lower cost sites of care, then we're probably not going to do it. But as we now have an expanded network, including many lower cost sites of care, and I would suggest, for instance, that there are hospitals within our system that are among the lowest paid in the entire state, and so we have those. Then you will see us move that care to those lower cost sites of service. They are now part of our system.
So Kevin has already talked about the incredible demand to get into the AMCs. So despite continued expansion of the emergency departments, patients are turned away all the time. High alert is a daily event. So the crush of patients who need to come into the hospital, both of our AMCs, is occurring all the time. So again, part of that is moving patients into a community setting where they belong. We also are and serve as the primary care providers for many individuals who live around those neighborhoods. So I think those points have already been made, the importance of moving care out, getting care at the right place. We've already discussed this many times. The most important thing I would emphasize here is how rapidly care delivery is changing and the disruptors in healthcare. And these are things that we're very cognizant of. So again, the concept that so much care could be delivered, now we're not talking about AMCs versus community hospitals versus licensed settings, but we're talking about freestanding ambulatory centers, and most importantly, we're talking about the home. So with the advances in technology, the kind of care, the degree of care that actually can be provided in the home is changing so quickly. I think when we're thinking about the future, we really have to think not only about those patients who are moving to community hospitals, because we're doing that for all those reasons, but the real question is how much care can be delivered in the home? That's the first thing. The second thing is, how do we prevent patients from coming to those emergency departments to begin with? That is a critical question we are all grappling with. If we can stop that early on by identifying those patients, and there are so many programs that we're all doing to try and do that, if we can do a better job of that, that will be really important. And the concern is that there will be these disruptors, whether they are Amazon or Walmart, who are going to come into the Commonwealth and take those patients who, they're for profits. They're not there to fulfill missions. They're not there to take care of all the patients we take care of. What does that mean for us? So we need to learn from a lot of those disruptors, but we also need to make sure that we incorporate that into our own business model and taking care of the patients we take care of every day.
So I would totally agree with both what Kevin and Ann said about the obvious shift from outpatient to inpatient. Most of our expansion is in ambulatory, and it's all specialty care. So it's all pediatric specialty care. In pediatrics, I think we are seeing a growing shortage of pediatric specialists in the community. So there really isn't anybody to partner with. And we are now providing services literally across the state and across New England in pediatric specialties. Out at Bay State, out at UMass, clearly up at Dartmouth, up at Maine, down in Hasbro. We're literally providing specialty services in those hospitals. So that's a regionalization issue that we're seeing not just at Children's in Boston and New England, but we're seeing in every community regionally across the country. Clearly, the reason for moving off the campus is also to get closer to families, to not have them have to bring their kids into Longwood, which is way overcrowded. There is no place to expand to. And so it's been a patient access, a patient experience opportunity for us not to actually just keep building ambulatory care in an expensive setting on Longwood. So for both those reasons, that is really the reason why we're expanding.
I'm just going to close with a couple of observations about things. One is care is clearly changing. My sense is that it's changing faster in other countries than it is here. So for all our talk of tele this and home that, there are other countries that actually do it, and we still talk about it. And so that's shame on us because we haven't figured out how to do that. Second observation, and this comes back a little bit to our discussion yesterday, to some extent the shame is on the Commonwealth as a whole because we have not addressed issues like administrative expenses that are contributing to very high costs, and I know that's something that you all tell the Commonwealth that it should be interested in, and that's something we tell the Commonwealth it should be interested in, but I think probably we as a commission have not pushed on that as much as we probably should, so shame on us as a commission. But I also think, just to come to Kevin's comment, which is that we've asked some of the same questions before, and I think probably the biggest difference between our asking the questions in the past and our asking the questions now is that the level of frustration in our voice is probably higher now than it was in the past. And that's reflecting the fact that all the data we see on consumers and on individuals and on patients shows the frustration, and they can't afford medical care and they can't get access to it. And so all this sort of stuff is out there, and yet people feel just incredibly frustrated, and that translates in. And I don't know exactly what we as a commission can do. I mean, we sort of raised the issues and so on, but I really think if we don't address this issue soon, we're going to have a hard time keeping our healthcare commitments. We're going to have a hard time addressing the people in Massachusetts. Remember, the average person in Massachusetts' income is not rising as fast as the mean income in Massachusetts. That is, the income distribution is getting more unequal. So in places like Brockton, you're seeing no increase in family income and throughout lots of the state. And so it's creating this intense pressure on the healthcare system. And I don't think that's a very good place for you to be in. I don't think it's a very good place for anyone to be in. So we collectively have to figure out what we're going to do about this, or else things have a way of going out of control, and that's not very nice. So if you have thoughts about what we should do about it, ranging from the HPC should do this to the Commonwealth should do that to whatever it is, like now is a good time to express them, or shortly from now is a very good time to express them, because really something is going to have to be done.
David, thank you. Oh,
Oh, I was just going to say, could we just also put a plug in for the people who are delivering the care
Yes.
in these institutions? Because, I think that there is no question that we are dealing with sicker patients, particularly in many of the hospitals, as we have moved a lot out. We are seeing more behavioral healthcare stressors. It is probably now the most significant employee injury issue that we're dealing with. The issues of stress and dissatisfaction among across, whether it's physicians or trainees or nurses or technical people. And so I think we also just have to be mindful that the people who we really are relying on to take this burden on every single day of taking care of patients, but also delivering better service, and at a lower cost, are the people we also need to be concerned about. They are very vulnerable at this time.
The irony is that this is the hardest working workforce in the entire economy.
It is.
They come in early, they stay late, they run around doing whatever. Like, unlike other parts where, comparatively, I have a much easier life than the people who work in your institutions. And so it's sort of ironic that it's sort of going to hit those people the hardest, and that's a point very well taken.
Can I just add on that, with the representative of the healthcare workforce on the commission? I think it's a really important point, and something that we need to struggle with and figure out is not only the current stress and burnout and mandation issues for healthcare workers right now, the level of complexity in their lives, the increasing cost of healthcare, stagnant wages as well. So I completely agree with that, and I think that's a really good topic for further conversation, for us to review the impact of all these issues on the actual direct care workforce, and that what are we all doing individually to make sure that they are earning a good living and they can take care of their families, get to their own kids' health appointments, to their sporting events or whatever they need to do, because right now it's a significant problem, and we know it's only going to get worse, where we know there's going to be a growing gap in the needs for healthcare jobs, and we don't have the bodies to fill those positions right now. And what we need to do, in my opinion, is, there's a lot of things to do. So I think we should have that discussion. That should be a further deliberation for all of us together.
We need to work together.
The only thing I would add to that, in terms of the kinds of thoughts and the things that Sandy has put forward in terms of the stressors on the workforce, because the workforce, that is really who we are, is challenges that confront them that, again, relate to where they're working, and this is particularly true in Boston. What we hear about all the time are the additional stressors beyond all the rest of it of transportation and housing. And people have a very hard time coming to work. They travel for a very long time, and it's very hard to find affordable housing near where they work. So again, it gets to this interrelationship that we keep talking about of the challenges of the Commonwealth, the different challenges that we all have together, and how they all fit together, and how many of the things we talk about ultimately land in the healthcare area and in our own employees there.
Yeah, goes back to the point Dr. Berwick made. I want to thank our panel for, I think, a very provocative discussion. Thank you very much. In the spirit of Stuart Altman, I'm going to ask each of our commissioners and actually all the head table to reflect on the conversations both yesterday and today. Give us your takeaway and your thoughts about where we go from here, given the extraordinary presentations and testimonies we heard. Cassandra?
I think I would say that I recently had the opportunity to work on the governor's health care bill a bit, at least towards the end, and it's been really heartening to hear so much positive feedback for what's in that bill, and at least the conversations that can continue as we think about the definitions that the bill tees up, and maybe some wholesale changes that can be made. So that's what I would say.
Ron?
I would summarize it by saying this is a very complex industry, and that complexity leads to increased revenue and higher gross margins.
Chris?
I think the frustration is that there's a lot of good talk and good listening, and translating that into action is it just doesn't happen because of complexity. And the reality is that 3.1% is $1.8 billion. That represents a wealth transfer from employers and consumers either in the form of taxation or out of pocket or their own insurance contributions to hospitals and insurers and doctors and the whole healthcare ecosystem. Everybody in this room is, or not everybody, but I presume a lot of people in this room are employed by a not-for-profit that is part of the healthcare ecosystem. So there has been a wealth transfer, and notwithstanding how hard people in the healthcare industry are working, I feel like we're one economic downturn away from something really ugly. This is to David's point. I think, in the old expression, when the pie gets smaller, the table manners deteriorate. And the pie keeps getting bigger in a growing economy, but if that doesn't continue, we will really be struggling. So a lot of good things, I think, in the hearings. We heard some very specific good ideas, zero co-payments for diabetes, some sense that the pharma supply chain could collaborate and figure out some solutions. I love the acute care at home. And I think the governor's bill has been highlighted. So I don't want to focus on the negative. There's positives, but we have to monitor these things and hold accountable some of the numbers that have been put out there. So
thanks, Barbara.
Throughout these 2 days, I've had the concept of complexity theory bumping into my head, and one of the phrases in complexity theory is that on the other side of complexity is simplicity. I keep hoping that is the case. We're not there yet. We haven't made enough progress fast enough. we keep focusing on the same frameworks. We keep focusing on reimbursement. We keep focusing on quality care, all of which are very important. But I would love to see us start to think about how we frame this conversation and broaden who we bring to the table to try to solve problems. As the innovation person on the commission, I kind of feel an obligation to continue to push and encourage for that inclusion. The other thing I want to say is it takes a lot of hard work to ask the right question. Too quickly we go into a discussion and we quickly identify what the question is and then we try to solve for the question, only to discover that the solution didn't work. And so one of the things I think about a lot is how do we ask the best question possible? If we spent more time on identifying the best question, maybe then getting to the outcome would have a better result. And so how do we ask the best possible question? And I think we have to challenge ourselves that when we start to frame a question, that we take a moment to say, is it the best question? And to challenge ourselves to say, maybe not. Maybe the way you get a really best question is to ask a lot of questions. Maybe the way you get the best idea is to throw out a lot of ideas. But I'd like us to start to think about using innovation framework and innovation theory to try to solve the broader questions in a field where innovation is tightly constrained to a very few areas, and people might disagree with me on that, but we have to make it easier to be innovative while still preserving and protecting patient safety and quality care. So I think we have a lot of conversations to have.
Thank you. I'm going to go back down. Eric?
Pretty often.
Yeah.
You did. Thanks, Vice Chair Cohen, and thank you, commissioners, for hosting these great hearings. I guess I'll just come back to the two themes that we continue to think about in our work in the AG's office, and that's ensuring adequate and good access to care at an affordable price for consumers and patients. And as we think about it, and I think appreciate the frustration from the commissioners on our attempts over the years at bending the cost curve, trying to think of more progressive and more innovative ways to get at that. And maybe we have the answers from as David said at the beginning of the hearings from Dr. Altman, that it is the price and it is administrative costs. But what are the more innovative solutions, regulatory or otherwise, to get at those problems? And then, but also not forgetting that access to care, especially for the most vulnerable patients in Massachusetts, is really paramount. And we should be thinking about, over the long term, that's 5-10 years out, how are we going to ensure that low-income patients, particularly in the communities outside of Boston, continue to have access to high-quality care, and keeping them at the front of our minds.
Thanks. Ray?
I'd like to thank David and Chair Cohen for the great hearings that we've had. These have been two really great days of discussions. These are really policy discussions primarily, and so I love listening to them and thinking about them at the policy layer, but then I look forward to going back to CHIA and talking with the staff there about kind of what is the data layer that is suggested by these policy questions. And I think that we have to, as CHIA, think about what we do to measure primary care, what we do to measure behavioral health, how well we understand the administrative complexities of the system, and whether we have data that shines a light on that. Some of the other topics we've talked about, and in particular affordability. We do a lot of work on that, but it's clearly becoming even more and more pressing than it has been. So for me, I think it's it's a matter of taking these really interesting policy discussions, and for CHIA trying to understand what data work comes out of that for us.
Great. David?
Well, I have a positive reflection. I think that the last panel certainly had some sobering moments of silence. But taking a step back, these hearings are really special and what we have here in Massachusetts and the level of discourse, partnership, and collective willingness to come together and disagree, to sit there in silence sometimes, is just a really, it is a unique thing that we have here. The other states that have been attending these hearings and watching online have been emailing and texting me, how did you pull this off? How does the state have a place where such brilliant commissioners can come together and ask all of the good, better, best questions, and to have all of the data and information to inform that so that we're really talking from a fact-based foundation. It is a strong foundation, and as I look out at the staff here, I think we have the team to be able to take on some of these big challenges. And as you and I both said, Commissioner Cohen, at the beginning, it's an inflection point, though, and we need stronger tools to make that happen. But I think we have the strong base and foundation for future success.
Thank you. Tim?
Yeah, just to pick up on David said, I mean, one of my reflections always at the hearings is just the amazing staff of the HPC and CHIA, and just the amount of work that goes into these hearings is amazing. And I think it was really great to end with the panel that we did with the kind of the industry leaders element, because it gave, I think we've done that at different times throughout the hearings I've been a part of. I think it felt really good to end there with this panel in particular. The one big thing for me is, I think we've talked about throughout the course of the last couple of days, is just centering our discussion around the consumer and how we're thinking about that. What are some of the things we can do right now to lessen the burden of the cost of healthcare on consumers? Because I think that at the end of the day, that's what this is all about. And we clearly got some work to do there. I'm hopeful as well. I think I did kind of ended on a sour note, I think, here. Kind of got a little depressing for a moment. But I think, again, the cost trends hearing is happening at a really important time. I think the governor's bill that he filed is going to start another great debate. I think this is the third time that I've said that's my one reflection, is that we have another opportunity to try to address some of these issues, and I think we're to a really good start on some of that. And again, it was great for me personally to end the conversation around healthcare workforce. I think it's really important that we figure out a space to dig into that conversation. I think the roles are adapting and changing. We talked a lot about home care in this panel, which I thought was really encouraging. The credentialing, the licensure issues, scope of practice, those are all important things I think we got to really dig in on. And they're also consumers of healthcare, and I think the increase in costs are hurting healthcare workers while at a time when they're more and more being asked of them. So I do think that'd be an important conversation to have, and I'm hopeful. I think that we have a big opportunity the upcoming session, hopefully, to get another bill passed that addresses some of these issues, and then we'll come back, continue the work. And again, to how you ended, David, I really do think the team here, both in CHIA and the state and the Health Policy Commission, we have the right group of folks to kind of work through this and try to figure out how to address these really important concerns that are impacting low and middle income workers more than anyone else. And that needs to be what centers our work between now and the next cost trends hearing.
Don?
Thanks. Well, first, as several of you said, the ability to work with the commission staff and CHIA is just a gift, an amazing team you built, David. We're working with information that I doubt any other state has, and it's and the ability of the staff to produce these analyses and then really give us something to chew on. It's extraordinary. So I've always done graciously. So thank you. And it's not the only resources. You listen to the testimony, and we got a Commonwealth full of smart people, good ideas, a lot of communitarian spirit, a lot of generosity. So that's all good. And there's some examples that really are very intriguing. Like, we heard much more about telemedicine this time around than ever before. It's a breaking frontier that's got to be optimistic. So that's the good news. I think the bad news is, which probably shouldn't have ended with it, you're right, Tim, but is we don't have the results, and people are in pain. And the doctor in me says, well, when the pain's there, respond with urgency. And I just don't see the urgency quite yet, not at the scale that we need. And that's what I'm leaving here, is wondering what could up the stakes a little bit. Part of it is no one's in charge. The excellence that each brings to this and their dedication to their work is evident, but the system is the issue here, and who's the systemic who's the thinker or the actor at the systemic level. The governor's stepping out. I think that bill sounds good, and we're going to have to take a close look at it, but it's a lot there. But we need systemic leadership. Marty said just before the meeting started 2 days ago, he said, we have a problem of will, and I think he's right. I think it's will to do something systemically as a total community. The ability to, I think it would start with systemic goals, and I'm starting to think that 3.1 is nice for a while, but that's not the answer. There's no reason this Commonwealth can't be more ambitious about reallocating resources from the technocracy to where the needs are. The governor said it. He said, let's move from transactions to causes and relationships, and that's pretty good. We might want to move off 3.1 or work with the legislature on a much more ambitious sense of reallocation of resources. The last thing I'll say is, it has to do with the patients and the people that are being affected. In the past 2 years, the two most impressive presentations have both been by small business owners. Cheryl yesterday, and I can't remember the person.
Stone, actually.
Yeah. Wow. I mean, you listen, they're living this, and I wonder maybe another year we should have a patient and the panel of impacted people right at the sharp end who are feeling the effects of action and inaction. I think that would be very helpful. The patient, with those people in the room, our sense of urgency could maybe even go up a bit.
David?
So I like to think of things in very simple terms. So from our first cost trends report back in 2012, or what I think it was, I kept pushing the staff, many of whom would yell back at me, can we just color code things? Like, I want green light, yellow light, red light, in terms of how we're doing it. Some of them will remember this. And so I still think along those lines, and my overall assessment is that what we get is a yellow light. That is, we've done well by some things, so since this law, we mean us as a commission, I mean since this law has been in effect, spending growth in the Commonwealth has fallen relative to the nation, relative to where it was, and so on. So that's all very good. There are good moments where people talk about things that have happened that have been very good for their patients and so on. So all of that's great, but it hasn't exceeded expectations in any way. That is, I think part of the spirit was that this was kind of a first step and then it would go beyond that. And I think we're having difficulty figuring out how to go beyond that part. And so I do think, along with everyone else, that something is going to be needed. My sense is that in studying health policy a lot, that proposals tend to be more likely to be not bold enough than to be too bold. Because in the end, you tend to focus around the lowest common denominator, which is sort of easy things, and then you don't get much out. And so I think what part of our agenda has to be to keep the pressure on being bold enough, not reckless, but bold enough so that the system really is pushing where it needs to go, as opposed to kind of skating along at some indefinite point reach where it needs to go.
Great, thank you. As the colorblind person on the group, please don't go back to red and green. So I said yesterday that I do think we're at an inflection point, and beyond the frustration and the sense of the lack of will to carry things out, I hope we are there. My sense is we certainly can be, and it's going to take some leadership across both the folks in the industry and government and the commission and other aspects of government. I am very hopeful, as the behavioral health representative on the commission. It's the first time in a long time, and I've been inside and outside government, that I heard the governor, the speaker, the Senate president, and the attorney general talk passionately about the need to address behavioral health in this state. And that's a long time coming, and the promise is terrific, and I have great hopes of what's to come. I'm also intrigued by the presentation of Millbank and the folks in Rhode Island. And I think given what the governor has proposed in the legislation that was talked about last week, I also see promise there. I think it's very exciting and look forward to seeing that discussion continue. So I leave here quite hopeful and recharged that there's a lot more that we can do both as a commission and as a Commonwealth. I want to take a few minutes to just thank Suffolk University for being such a great host to us. They've done this numerous years, and we are grateful to them for making their space available. I know the law students hate it. Again, I also want to share with my commissioners to thank both the staff of the Health Policy Commission and CHIA for the excellent work that goes into these, not only these 2 days, but all of the information and data that we get, as well as to the folks in the Attorney General's office for their great contribution to that work as well. And David, for your leadership, thank you. Lastly, Stuart, if you're listening, which I hope you are, please get well soon, because, chairing this is not as fun as it looks. So we look forward to your coming back, and hope you feel better. And with that, if there's nothing else, I think we'll adjourn.
Thank you.
Great job.
Nicely done, Marty.